Thank you so much.
Well, welcome everyone. My name is Chuck Degeneffe, professor of rehabilitation counseling at San Diego State, also chair of the Department of Administration, Rehabilitation, and Postsecondary Education, and very happy to welcome you to today's Lunch and Learn event featuring Sarah Price Hancock, who is a proud alumnus of our rehabilitation counseling program. I've had the honor and pleasure of knowing Sarah for around 14 years now, and I'm always impressed by her work and her passion for the field. And today, Sarah will be giving the presentation, Electrical Injury Rehabilitation Needs Through the Lens of Electroconvulsive Therapy Recipients. This is a topic that Sarah has connections to both personally and professionally. And we'll be sharing, I think, some really important things for us to consider as rehabilitation counselors, as advocates, as just people interested in this topic. So again, welcome. And if you're interested in the CRC units later in the presentation, I'll be giving my email address, and then email me if you would like the one CRC ethics unit for today's training. So with that, Sarah, I'm going to turn it over to you, and welcome, Sarah. Great to see you here today.
Thank you so much, Chuck. This has been something I promised myself that I would do if I ever had the opportunity to be able to obtain my rehab counseling degree. I promised myself that I would use it to help people in my situation. And so you're inviting me to give this presentation is really a fulfillment of that promise that I made to myself. So thank you so much. It's been an honor to be here and to take what I've learned from the rehab counseling program and what I've learned from my subsequent studies of electrical injury and ECT. And so with no further ado, let's get going. So let's see what I've got here. Can you see my PowerPoint? Chuck?
Yeah, I can see it. It's good.
Fabulous. Okay, so here we are. This is me. I'm, like you said, I'm a graduate and former adjunct at San Diego State in the rehab counseling for the clinical psychiatric rehabilitation. And I do have my CRC. And I did host the podcast called the Emotional Self-Reliance Podcast. But right now, my entire focus is on the Ionic Injury Foundation. I'm a co-founder and trustee of that. So today we're going to be talking about the electrical injury and who's at risk and how does it impact employment and how is electrical injury a traumatic brain injury, and then I'll share a case study, and then we'll discuss how rehab counselors can help people in this situation. So when we think of electrical injury, I'm certain that most of us think about people who work with electricity. We're talking welders and linemen and electricians and those kinds of things, and you are completely right. So I borrowed this information from a colleague who researched electrical injury. His name is Dr. Mark Yeske, and he is the VP of Translational Research at Hamilton Health Sciences up in Canada. He works very closely with people who have electrical injury, and he's done a lot of research. So I borrowed this from him. This is based on Canadian information. And let's see, electricians, 31% of the people that he sees are electricians in that time period. 17% were linemen, journeymen, and 14% were like technicians, maintenance, and HVAC. And then the other 45% were people who had gotten shocked on the job in a variety of other situations, as you can see. So the interesting thing is about, sorry, I'm just getting a little ahead of myself here because I wanted to give you American information since we're located here in America. And so, Chuck, would you mind reading this bottom part here to save my voice?
Sure.
Thank you so much.
The Occupational Safety and Health Administration, OSHA, considers electricity to be a serious and long-term workplace hazard. Electrical injuries can result in severe physical and financial consequences for workers, as well as impact a company's productivity. OSHA reports that every 30 minutes during the workday, a worker is severely injured by electricity, that time off from work is necessary to recover. And here are some statistics about electrical injuries in the United States. Fatalities. In 2023, electrical injuries were the leading cause of fatalities and injuries. In
At
2020,
work, sorry, at work.
oh, sorry.
I
In
didn't have
2023,
that.
there were 30,000 non-fatal electrical injuries. Cost. Non-fatal electrical injuries can cost between 1 to 4 million per incident. In common scenarios, the most common scenarios that lead to death include direct contact with a live power line, direct contact with live equipment, vehicular contact with a power line, and then recovery. Recovery from electrical shocks is recognized as a slow and painful process. OSHA reports that every 30 minutes during the workday, a worker is severely injured by electricity, that time off from work is necessary.
Thank you so much, Chuck. So let me get back into my presentation mode. So the reason I'm asking Chuck to read periodically some of these slides is because my voice gets more tired the more I use it. And I want to be able to save it for questions at the end. So electrical injury has both immediate and delayed consequences. And many of you who know me, if you studied with me or either as part of my cohort while I was in the program or one of my students, you didn't see me in a wheelchair. And that's a consequence of the delayed impact. So typically when we talk about electrical injuries, I'm sorry, this is graphic. This is from my dear friend, this burn surgeon. But he was explaining that electrical injuries, there's a burn on skin and the underlying tissue and can result in loss of muscle and fat and bone, can affect the heart function and the rhythm. It increases the risk of organ failure, and it can affect the cognition and the mood and the behavior, the vision, the caring, and that can result in fatality. And the hard thing is the full impact of electrical injuries is often not immediately recognizable. And to illustrate that point, I just want to share a video with you from Dr. Mark Yeske. This is from when he was at Sunnybrook Health Sciences, but he's now transferred to Hamilton Health Sciences. So let me change my sharing so that I can go to the say, change my sharing to, sorry, I am not as practiced in this as I would like to be. Let's see, share. I need to share it to YouTube. Right, there we go. So in this clip, he's talking about how when the electricity has no resistance, so that means it can go right into whatever it's going into. For example, if the person was in water, or if they were wet for any reason, or in the case of electroconvulsive therapy, they have a gel underneath the electrodes. So the electricity goes right into the nerves and the vascular system instead of causing a burn at the top. And so he's going to be talking about how difficult it is to help people who have invisible electrical injuries.
Well, and we're going to get to those interesting times, I think, actually, perhaps right now, because back in 2010, I had interviewed Dr. Joel Fish.
Can you hear that, Chuck? Fabulous.
At the time, Chief Medical Officer of St. John's Rehab, and the subject was about invisible electrical injury. And during that interview, he said, I myself, in the beginning, did not believe this existed. Now, a decade has gone by since that interview with Dr. Fish. So, outside of obvious electrical injury, like a burn, how have attitudes changed in the medical community or outside the medical community with regard to invisible electrical injury?
Frustratingly, I would say not a lot. And again, it's very frustrating because we still struggle to educate not only, one would think, well, healthcare providers should know, but even healthcare providers struggle to recognize that low voltage injuries that you can't, that are invisible, are falling off the cliff because there is no evidence. We know that all the testing is negative, and obviously when you have negative testing, well, it must be all in your mind, and it doesn't exist. So I had also a learning curve because in pediatrics, you do not observe this low voltage with the significant mental health and other components. You don't. And so it was a learning curve for me as well, which took some time, but I really, the amount of patients we saw and how this developed, I actually would underscore what Dr. Fish was saying. And I really struggled at the beginning. It's like, wow, there is a significant impact of an injury that is not being recognized. And you don't have testing. And you run EMGs, EEGs, MRIs, CTs, and you name it. You do all the testing, you don't find anything. And again, believe me, even in medical professionals, it is still not completely accepted, let alone insurance agencies, other workmen's institutions, or even employees, even companies. To this day, people struggle to get accepted and to be recognized to have had an electrical injury. So it is not very well accepted, and this is very sad.
That I can only just imagine how frustrating that can be for the sufferers of an invisible injury, for yourself and your team who know it to be there but don't have those hard results that you can show someone.
Right.
Now, over the past 10 years, and without making any assumptions, I'll put the question to you. Now, have there been any advancements, at least in identifying or better understanding electrical injury with the research that you and others have been doing? And where you're concerned, are there any particular research tracks that you're engaged with now?
I think there's several things we learned over the last 10 years. First of all is really the impact that low voltage electrical injuries can have. So being recognizing, and then we here locally in Ontario work very hard in various aspects, insurance, workman's comp, to really get this recognized and fought for our patients to saying it happens and it's real and you need to be aware of this, and we need to work together as teams in order to get this forward. And we went many times. We actually went to WSIB, it's our workman's comp, down physically to present and educate. So there's numerous times. And I think that is something that improved. Research-wise, I think there is a little bit more understanding about what's going on in terms of the cell. So we're doing some research to understand what is actually causing, and is this inflammatory? How is the electricity causing those changes? Inflammatory driven, is it by cell membrane, is this permeability, or what is going on? There are various cellular components that we are trying to understand, and I think we made some advancements. We still don't unravel the mystery. And so it's very difficult to reliably and objectively identify the sequelae of a low voltage electrical injury still to this day. But there are some notions, and as I had in my talk, there's something called channelopathies, where your cell channels are being affected, because you need to remember the voltage by which these channels act are much, much lower, even when you have 10 volts going into your body. I mean, if you lick a battery, you can have a low voltage injury and nobody ever will know this. You can have sequelae.
All right. Well, we'll get more into that later in this presentation. But thank you. Let's get back to my sharing of the current screen. Wait, are we good? So just by looking at his data, this is some of his research. We have this is the equivalent of the American workman's comp. This is up in Canada. That's what those initials up here stand for. And so basically it's showing that claims for electric shocks were 18 times greater than claims for third-degree burns. That's 55% versus 3%. And that's specifically for workman's comp. So in looking at his research, in terms of when he was talking about low voltage electrical injury, that's anyone who is historically it's lower than 1,000 volts. And so high voltage is over 1,000 volts. And they're looking also at instead of looking at voltage, they're now looking at current instead of voltage, because current can be more accurate in terms of looking at these injuries. So looking at this, as rehabilitation counselors, it would be very concerning to us that 22% of the people were unable to return to work with low voltage injury, 15 with high voltage injury. And the good news is a return to work to their pre-injury occupation for low voltage injury, 61% were able to return to their pre-injury occupation. But of that, 57% needed modified duties and 57% needed a modified schedule. So that's kind of giving you an idea of the kinds of injuries that these people are living with, since these people, after one shock, they were able to return to their preferred occupation with modified duties and with a modified schedule. So that's actually really something to remember as rehabilitation counselors. So in terms of the symptoms of diffuse electrical injury, now you might be thinking, diffuse, what does that mean? So diffuse is when I get shocked on my head, that doesn't mean that the electricity stays here. Anytime the electricity hits a vein or a nerve, it's diffused into the vascular system or into the nervous system via the vein. And so with these electrodes, they're covering multiple veins, multiple nerves. And so you can see they don't cause just problems where the person was shocked. And so if you check, could you just read a couple of these things that have, more than 50% of the problem?
Sure. Muscle aches, 62.5%. Muscle spasms or twitches, 52.94%. General fatigue, 50.74%. And the general physical weakness, 50%.
Thank you, Chuck. And I'm just going to throw in here the general exhaustion, because let me tell you, it's serious. But I circled these other boxes in red because those are specifically the boxes that are dealing with people who had low voltage injury. And a little bit later in this presentation, I'll talk specifically about how much voltage is used and current is used, what kind of electricity is used in ECT. But the interesting thing also is that in the work environment, you can have like an immediate flash injury or like an arc injury. And that's just an instantaneous one and done shock. So these are pretty serious things. But then when you get into using a device, the settings on the device will control the dosage. And these doses can do alternating current for as much as 8 seconds. So for example, the dose that was used on me was 8 seconds of current, almost 0.9 amperes, and that was pulsed 1,120 times in those 8 seconds. And that's with alternating current. So the alternating current means that it's positive and negative. So everything's like a magnet pulled to one side of the cell and then pulled to the other side of the cell. 1,120 times in that 8 seconds. And that causes what's called electroporation. It causes holes to rip into the cells. But I'm getting ahead of myself, so I'll just go back. These are some more of the things that can be caused by the diffuse electrical injury. And as you can tell, they're quite diverse in the causes. And I want to remind everyone that these are electricians, these are linemen, these are people who do not have a primary diagnosis necessarily, psychiatric diagnosis. These are healthy individuals who are working full-time. And so, when you see some of these psychological things that are having problems like unexplained moodiness and lack of motivation, these are healthy individuals reporting these problems. Memory loss, those kind of long-term memory loss, these are healthy individuals. Cognitive losses, reasoning skills, 23%. These are among healthy individuals. So these are things that we need to remember as rehab counselors. And then we've got the delayed electrical injury. Now, the delayed electrical injury can set in between 6 months to more than a decade after the person is shocked. And it really depends on the intensity of the electrical field strength, the age of the exposure when the person got shocked, and then how often they were shocked. So looking at some of the other research that was produced by I thought this was produced by a gentleman here in San Diego because I've read all of the electrical injury research, but I got this one confused with, there's a gentleman in San Diego. His name is Dr. Morris. He teaches at the University of San Diego, and he's a lawyer, and he also has a degree in electricity. I don't remember off the top of my head what it is, but I've spoken with him. We've had a wonderful conversation, and he has a website that's the electrical injury, I believe it's .org. It's at the end of this. And he has been running and publishing on his survey findings. People who find him and they take his survey. He's been publishing regularly on the long-term effects of this. And so, excuse me, Dr. Morris, for having confused all of your publications with this one, but this one was used with permission from my friend, and so I just assumed that since it was part of the survey that this was from his website. But this is from Dr. Fish, the gentleman earlier that they mentioned, who said that at first he didn't think this was a thing. And he began realizing that it was a thing as he was tracking his patients who came into their burn center. And so, as you can see, there's quite a lot of consequences. There's the contact, like where you hold and grab on and can't let go, perhaps, in a vocational setting, or the flash, which is exactly like it sounds. And so, these are long-term consequences among their patients. And when it says 80% of specialty consultations were negative, this is interesting. When they say negative, that means they didn't find anything on the test that they ran. And that can be very challenging for someone who's experiencing very real physiological symptoms. And I was speaking with Dr. Morris about this, the gentleman from USD. And he was explaining that, before the advent of the X-ray, people said that if they couldn't see a bone, it wasn't broken. And we know that now we have the advantage of being able to see these broken bones in x-rays. And like Dr. Yeske was saying earlier, you know, we don't have the capacity to see these cellular injuries on standard scans, but we are beginning to learn what those injuries might look like and how we can identify them. So here are some more of the testing that they did and whether or not they were able to find problems. And again, this is really frustrating as an individual who knows that they were fundamentally changed, and they keep going to their doctor and asking questions and getting tests, and all of these tests come back saying that they're, quote, normal. I have one doctor who finally said that I exist on the abnormal edge of normal. But again, that's just because we haven't yet identified how to properly measure these deficits in the body. Because like Dr. Yeske says here, 72% of the diagnostic tests were also negative, meaning they did not see any damage. But yet, even though they didn't see these damage, these are the things that the people were reporting when they were interviewing these perfectly healthy, otherwise healthy prior to their shock on the job. And if you look at these, I mean, Chuck, what are some things that stand out to you among perfectly healthy individuals that were shocked at work that have long-term after 6 months?
Well, all of them. I think this speaks to the magnitude of what you're saying here, you know, and it's and then it's especially frustrating then the tests don't you know identify this, and that there's a general mistrust or non-believing among physicians regarding this, because you know this kind of reliance on their current diagnostic approaches.
Yeah.
Some of the things like muscle aches, unusual anxiety, unexplained sadness, weakness in joints, which I think for all these things, they can be misdiagnosed or misattributed, that people could say, it's due to some other factor, or you're making it up, or whatever. So, I think this and among your other slides really just speaks to how complex, the issues are involved here.
Thank you, Chuck. It's true. It's so difficult. So for the last, since 2009, I've been also subject to all of these tests. And finally, because my symptoms were becoming more and more obvious, like you can hear my hoarse voice, and sometimes it's very slurred. Finally, my doctors were saying, your test came back normal, but clearly there's something wrong. And so they began saying that clinically the test was normal, but my clinical manifestation is such that they believed it was a central issue, which means that though they tested, for example, my arm or my bladder or my tongue or my back, that they were, or my ears, they were beginning to realize that it wasn't a problem with the external organs from my brain. It was a central issue, problem with my brain. And that fits with the, what's it called? That fits with our early, what's it called? Early findings in electroconvulsive therapy, because in early findings, they were saying that there was global dysfunction. I understand global dysfunction. So electroporation is one of those things you can't see under a scan, like an MRI. And that's because it really can only be seen when you're looking under a microscope. And in this case, this is a believe, a form of an electron microscope. So this is magnified thousands of times more than what an MRI could. But this is a cell wall. Before the pulse is on the left, and then after that pulsed, fast pulsed alternating current pulse, that's what it looks like afterwards. And so I put this picture of the wiffle balls there because it's kind of indicative of what's going on. They use this technique actually to kill cancer. And they also use it, I mean, this technique is made famous recently with the COVID vaccines because this technique is also known as the CRISPR technique, where they rapidly pulse it and it permanently changes something so that things can get into the cell, out of the cell. And so I tell people that my nervous system has been CRISPRed. But Dr. Yeske also mentioned the channelopathies. So, I mean, this is a new word for me. So channelopathies are cells communicate by passing electrolytes back and forth to each other. And so channelopathies, those electrolytes go through channels. And so channelopathies is when the channel is broken, has pathologically broken, and that's why they call it channelopathies. So sometimes these channelopathy diseases are genetic, right? We have people who have difficulty regulating potassium, difficulty regulating sodium from birth. But then there are other individuals who's been chronically exposed to electricity, and our body is a bioelectric wonder. And so we develop these broken gates in our channelopathies. And so when these gates break down, it causes problems communicating, pushing those electrolytes back and forth across the cell. And so it's really strange. My symptoms will wax and wane based on what I've eaten, based on the weather. If it's a high barometric pressure change, low barometric pressure change, your body passes electrolytes back and forth across the cell membrane. That's how it communicates with each of the cells communicate. So electricity and electrical injury fundamentally changes how the body uses electrolytes. And the shifts in electrolytes alter our nerve impulses, they alter our muscle tone and our strength and our coordination. So, Chuck, would you mind reading this quote from the meeting that we were in?
Absolutely. The neuropathology of electrical injury and the neuropathology of people with a history of electroconvulsive therapy is well recognized and should be considered through the context of both repetitive traumatic brain injury and repetitive electrical trauma, because the natural laws governing electricity's contact with the human body are not changed by benevolent intent. And that's Dr. Bennett DeMalo. And that was at the I think it was 2019 or 2018 at the TBI Advisory Board meeting, California Department of Rehabilitation.
Thanks, Chuck. But would you mind reading this? Because I don't want people to think that I'm throwing shade or stigmatizing a medical treatment that is safe. And if you would read a lot to me, if you could please read this.
Sure. So this is things to remember about ECT. Number one, it's not FDA approved. Secondly, ECT current is without clinical or scientific rationale, and that's from a study in 2021. Also, the FDA has not recorded safety testing on humans. There are more than 1,000 possible doses of electricity on modern ECT devices. The FDA has no record on dosing consensus standard protocols. No two people will have the same results. And manufacturers of the Thymatran devices were found guilty in federal court of failure to warn of permanent brain damage and permanent memory loss risk.
Thank you, Chuck. So that's really important to remember. No two people will have the same effects of ECT because first of all, no two people have the exact same dose. And second of all, no two people have the exact same head size and head shape. So if you look at this image to the right, these are just 4 different individual head sizes, brain shapes, and they're all being tested with the exact same dose. And as you can tell, when you look at the far right, that electrical dose disperses into the brain very uniquely with each individual. And so that's one of the reasons that we cannot compare. You can't compare individuals with brain injury, period, but you can't compare individuals with ECT injury either, because these electrodes get placed in different places and also they go through the body in different ways. And that is why when the FDA gave a provisional reclassification of the device, they required a warning put on these devices and in prominent places where the devices are used that say that the long-term safety and effectiveness of ECT has not been demonstrated, and that long-term follow-up may be needed. So you might be wondering, how much electricity does ECT use? Well, let me share with you. This is a clip from a movie that we're making called I Am Sarah. It's a documentary. And this is Dr. Kenneth Castleman, who is a former NASA engineer. And he's a senior member of an organization that studies electricity's impact with the brain and electricity's impact with the body and electricity in general. And he was one of the forensic expert witnesses in that court case where the jury found the manufacturers guilty of failure to warn. So let's just listen to his explanation of how much electricity is generated by these devices.
Sarah, the volume's not coming through, so I think you gotta share it separately.
Let's see. Okay, I wonder why. I'll share it from the other website. Let's see. Thank you for your patience with my technical difficulties. Okay, can you see him again? Let's see. I don't know how to share the sound. That's my problem. Do you have any guidance on that, Chuck?
Well, if it's coming through your computer audio, it should be able to pick up through Zoom. Let's play and just see what happens.
Okay. Oh, let me stop share again and let me just make sure that I select the share sound, because that's important. Okay, here we go.
Comparisons on the amount of electricity. The voltage that is available at a standard electrical outlet is 115 volts. The maximum voltage that an ECT machine can apply to a patient's head is 450 volts, which is about 4 times what's available in a light socket. The amount of current flow that's considered the limit for safety is.
Oh, sorry. We're doing this. We're going to do this for sure. Okay, let's try this again. I appreciate your patience.
Here are some comparisons on the amount of electricity. The voltage that is available at a standard electrical outlet is 115 volts. The maximum voltage that an ECT machine can apply to a patient's head is 450 volts, which is about 4 times what's available in a light socket. The amount of current flow that's considered the limit for safety is 6 milliamperes. An ECT machine delivers 900 milliamperes to the patient's head, which is 150 times what is considered safe. It's 150 times what a taser can use to disable a suspect. It's over 100 times what an electric fence uses to turn a cow around. And it's 150 times what the shock you would get, the current you would get if you touched a spark plug in an automobile. So the amount of electricity that's delivered to the patient's head, it amazes me that a human being can withstand that much voltage, that much current, that much power, and that much electrical energy. It's only about 1/5 of the current that the electric chair uses. It's really just a huge amount of electricity delivered to the patient's head during an ECT treatment. Here are some.
Oh, sorry. Okay, so when you're thinking of electrical injury, we're going to add our little ECT device up to the top here. And then because Bennett Amalu said that the natural laws governing electricity's contact with the human body do not bend with benevolent intent, down here I've also added one of the transcranial magnetic stimulation devices, because that is also generates electricity with the electromagnetism, and that is chronic exposure as well. The individuals sit in that device for 20 to 40 minutes at each session. So in terms of my story, to give you the full synopsis, I'll let you read it right here because we're running out of time, and you can listen to it on the podcast, which I'll link it to, that was done by the CRCC. So I'll share that with you in later, but let me just give a brief synopsis with some commentary from my dear late mother. Also a clip from the upcoming documentary.
Who are you?
That was, I really had to recreate that after a shock treatment.
She didn't know who I was. And all the way home, she's going, yeah, who are you again? And I'm thinking, something went wrong.
I have basically lost the first 36 years of my life. When you think about it, all of your relationships are built on shared memories. I will lose the capacity to recognize my family's faces again. I will lose the capacity to speak clearly. I will lose the capacity to communicate.
Now, our top story this morning is a bit of an exclusive for BBC Hereford and Worcester. This is something that we've been investigating, and it's being described by former patients as one of the longest running medical scandals in British history.
18.75% of patients were suffering severe permanent memory loss, and I don't understand how after finding that hasn't pushed them on to get this testing in place, because not testing destroys lives.
Oh, Sue, I'm just, I've always felt such like you're a sister warrior in this. I'm so grateful for your help.
Well, I said to you ages ago, we were more likely to be able to crack it in the UK.
This is a relay. We've been passing the baton back and forth, and we've stood.
I know, it's made me feel really, it's just spending the time that I had to do this interview so took it out of me. It just made me ill for weeks. When they said, we know we're harming people and, we're using the wrong tests, and yet chose not to do anything about it and never published it on their own website to say, well, this is what we've discovered.
Yeah, we've been trying to get people's attention for decades. They've been shocking people for 80 years, and they just don't pay attention to us. I guess the reason why I'm getting emotional is because we're just like, there's a dam. It's like a huge dam, and there's so many cracks in it, and there's literally decades. 2 million people a year, they said in 2006, and in 2018, America had a 34% increase in the number of hospitals providing shock. There's hundreds of thousands of people that need help.
Who are you?
Sorry. Let me figure out how to do this. So I'm just gonna put this here. Episode 9 of Inside Rehabilitation Counseling kind of goes through how I discovered that I had a brain injury. And it was actually identified first by, sorry, I was wearing sunglasses in an interview, the Disability Student Services Office at Wayamaka College. And the dear rehabilitation counselor sitting behind that desk asked me why I wasn't removing my glasses while talking to her. And I told her it's because it's too bright in here. And as we went through all of the symptoms, she kept asking me about post-concussive syndrome. I was checking all of the boxes, and she said, I hate to break it to you, but you have a brain injury. And I just laughed at her, honestly, because I hadn't been in a car accident and hadn't had a fall, never done drugs, never even tasted alcohol. And she's telling me I had a brain injury. And I was like, no, I don't. And she said, I'm sorry, Sarah, but something happened when you had all of that shock treatment and you need to get a brain injury assessment. And she asked me what I wanted to do with myself because I had no memory of my bachelor's degree, no memory of my work experience, no memory of any of the things I'd done prior to ECT, which included transcribing oral histories, working as an editor for faculty papers at the Brigham Young University and their humanities department. And it included being a university interpreter for the deaf and simultaneous, what's it called, American Sign Language. And I'd lost all of that motor memory. And she said, well, what do you want to do with yourself? And I said, well, I need help, but there's so many people like me who need help. I want to do what you do. I want to help people get the help they need. And that's why I became a rehabilitation counselor. So Dr. Amali said that we need to look at people who have a history of electrical injury also through the lens of traumatic brain injury. And you might be wondering, how is electrical injury a traumatic brain injury? Well, the long and short of it is this, but I will let you know. So, according to the Department of Defense, traumatic brain injury severity is based on the length of time that the person is unconscious. So, mild is 0 to 30 minutes, moderate's 30 minutes to 24 hours, and severe is more than 24 hours. So in ECT, lots of times they think, well, the patient gets put to sleep, so that's different. Well, that's true. The patient is initially put to sleep. This is typically like the gold standard for shock treatment, and it puts people to sleep for 5 to 7 minutes. Unfortunately, after that has worn off, the people wake up 10 to 45 plus minutes after they've had shock treatment, after they were given their dose of the what's it called, anesthesia. And so why are they still asleep? Why are they still asleep after the anesthesia wears off? And basically ECT is an internal blast injury. Anytime you get shocked, it's an internal blast injury. So because you touch the wire or you get the electricity, and during that shock, your heart rate goes through the roof, and that cannot be controlled with medication during the administration of ECT. And because if they control it, then it increases the risk of death. And I'll explain more why later. But so during the shock, the blood perfusion, because the heart rate's spiking. Oh man, I'm missing my doll. That's okay. It'd probably be triggering to a lot of ECT recipients watching this, and I don't want to trigger my friends. But it's like, have you ever seen those dolls where you squeeze them and their eyes pop out? That is kind of what an internal blast injury is, because the blood perfusion spikes 3 to 4 times normal. The eye pressure spikes to over 200 in the one study that I saw. And pathological is just 60. So that's concerning. And when this blast injury occurs, it activates microvascular structures which can rupture. And when they rupture, it leaves behind iron deposition. So the interesting thing is, I guess my slides are a little out of order here, but let me just continue here. So the shock, initially here, this is an actual slide from a presentation given in 2019 on electroconvulsive therapy. You can see the person's having a seizure. Those are actual seizure waves. And then you look at to the right here, all of a sudden it flatlines. And that's isoelectric. There is no brain activity, or very little brain activity. And that's because the body has completely consumed, the seizure has consumed all of the oxygen and all of the glucose at 200%. And so typically you consider if you are without air for 4 minutes, that's typically when brain damage begins. But when your oxygen has been sucked out of you by a seizure, it, in this case for ECT, is just in 2 minutes. And so the other thing is that the electricity frequently stops the heart from beating. And so that stops the blood from getting pushed through the brain. So initially there's that blast, and then there's no more blood. It's not moving. And so, like, for example, here, Chuck, would you mind reading the yellow portion?
Sure. So 17, it was followed by periods of more or less complete electrical silence, which lasted for times varying from 22 seconds to 6 minutes, 40 seconds after the seizure.
Can you imagine not having brain activity for 6 minutes and 40 seconds? So these injuries off to this right here, These are like the microvascular ruptures that can't be seen like on an MRI. But recently I was talking to a gentleman who specializes, he's a neurologist, now retired. And he told me that if I wanted to see my injury, I needed to look for what was left behind. And that is the iron. The iron gets left behind. Iron shows up as black on, what's it called? On a brain scan for under when certain kinds of brain scans are used. And that brain scan in this instance is SWI or SWAN. So I had a SWAN imaging in 2020. And as you can see here, this was just pointed out to me in my appointment this past week with my neurologist assistant. He circled this and showed that this is not a vessel. It is actually iron deposition. All of that is iron deposition. And if you look over at this one in the middle, that is what's in charge of like your memory. Mine is all black because it's microvascular ruptures there. And then there's up in here, this is extra blood that's filled in from atrophy. And then over here on this right side, if you can see where my arrow is my arrow there, Chuck?
Yes.
Okay, so this is what's called a silent bleed. That's chronic microbleed or telangiectasia. And you can see the iron that's just draining into my nervous system. So this is called siderosis of the central nervous system. And this siderosis is problematic because when you have iron in your brain, it oxidizes, and I have iron in my, since this diffuse electrical injury went all the way down my spine, I have iron deposits likely all the way down my spine as well. So going back to the changes in blood flow, this is interesting because they had people draw clocks. They were interested in looking at how the blood was used in the brain during ECT. And so they had people draw clocks. And at the beginning, here's our person that drew their clock before ECT. Notice the numbers are all in pretty good order. And then you can watch, this is the exact same individual through the course of this exam. And you can watch how the blood is returning to their brain and turning off and turning back on. And finally, 29 minutes after their shock treatment, they finally have full perfusion again. So even though the person has woken up after their coma, which could have been, 22 seconds or 6 minutes, I mean, that's just the absence of brain activity and then waking up afterwards, after it from the coma, these are, and ECT isn't just one treatment, unless the person is killed in the first treatment, which I know a dear woman who was, because she had a rupture. So it's not just one treatment, it's multiple treatments. And in my case, it was 116 treatments. So this is, for a while, they were saying, oh, look, the brain is healthier, it's getting in large structures and these areas that cause problems with depression. So look, they've gotten bigger. And what they discovered is that, yes, initially they get bigger. So if you look at on this left side of this graph, the starting point is the baseline brain size. And then immediately after their ECT treatments, their brain had swollen. And the reason we know it was swollen is because 2 years after their treatment, that swelling has gone away and there was a reduction in the gray matter. And so the middle group is the treatment as usual group, and the other side is the people who are the healthy controls. So we need to, Chuck, would you mind answering or reading this slide?
Sure. How can rehabilitation counselors help? Acknowledge electrical injury as TBI and electrical trauma for intake. add specific questions about electrical injury history, vocational, domestic, and medical EMS. Ask about brain injury and post-concussion syndrome symptoms. Ask about electrical injury symptoms, and advocate for electrical injury rehabilitation policies.
Thanks, Chuck. So these are some of the evaluations that can be done. Chuck, would you mind?
Sure. Motor function, including coordination and speed, strength, balance, and stamina, hearing, central auditory processing, hyperacusis, central neural hearing loss, for vision, central visual processing, motor tracking, depth perception, color sensitivities, for speech and language, cognitive communication disorder, aphasia, apraxia, dysarthria, or aretha, iron deposition, brain and spinal cord, tissues, lipedema, I'm totally mispronouncing it, lipedema,
That's okay.
chemical sensitivities, and then hyperelectrical sensitivity.
Thank you, Chuck. So this is me doing my box and block test, one of our favorite tests. Oops. What can you see, Chuck? Let's see.
Nothing right now. There's nothing being shared.
Okay. Okay. So as you can see, I'm having a difficult time figuring out how to open my fingers to release the block. And so I'm cheating by spinning the blocks out of
You're doing good.
So initially I start being able to just do it really fast, but then my motor system starts breaking down as I'm going as fast as I can. And anyway, we're running short on time, but you get the idea. Okay, so I need to go back to my presentation. Chuck, how are we doing on time?
We're about 7 minutes over. I mean, so maybe.
Oh, okay.
Wrap it up in the next
So
5 minutes or so.
there we go. There's the nystagmus testing. Basically, the longer they did the evoked potential of me watching things, I won't show the video, but here are some reasonable accommodations. Chuck, would you mind?
Sure. Accessible work environment for mobility, ionic air filters and HEPA filtration, ergonomic work environment, wired electronics instead of Bluetooth, alternative augmentative communication, and CART, quiet work area such as ticking clocks, flexible scheduling, written directions, printed materials in alternate formats for screen reading software, lighting, and then restroom breaks.
So the ticking clock joke is when I was in the program as a student, the poor teachers, every time I'd go to class early and I'd remove the batteries from the clock because my trigeminal nerve is damaged. And so I hear all noise at the same loudness. And it was very difficult to focus on just, for example, Chuck talking about assessments or Mark talking about statistics when I've got all of the students around me typing on their notes. And I was when I did my testing, I qualified for double time on tests, and I qualified for notes from my tests, and I qualified for a note taker, and I am eternally grateful for Denise and some of the other note takers that routinely took and shared notes with me. But because I had these reasonable accommodations, I was able to complete my training and go on to research. And so these are some of the assistive technology things that you can consider for rehab counseling. So there you have it. I'm excited to let you know that we did complete a survey just this last September. More than 800 recipients responded, and more than 300 family members and friends responded. And so I'm working on publishing these results, analyzing and publishing these results. We have enough material for about 8 to 10 papers, and we've already submitted our paper specifically regarding memory loss, excuse me, and our paper on efficacy. So it's just a matter of time, and good. I'll take some time to recuperate from this presentation, so the one on employment might take a bit, but don't you worry, slow and steady wins the race. So here are some resources for you. And I know we're over, but if there's anyone who has a burning question, and Chuck, if you have time for a burning question or comments,
Sure.
now is the time.
Sarah, are we able to get that that .org? I looked at electricalinjury.org. I don't know if you can mail it out afterwards. Or you can just mail it to me. But
Yes.
thank you so much for being out and for talking about this and pushing this forward. It is such a huge thing. It was life altering for me. As you know, we've known each other. We met in grad school. And it's taken a long time for any people to recognize this. And I want to also do a shout out to Chuck for, seeing this and helping with this. So thank you.
Thank you. Well, I think we're at the end of our time. And Sarah, I want to thank you for an incredible presentation, very impactful for me, and I'm sure for everyone here today. And, I just really, I appreciate you sharing of your personal story and putting light on this topic and advocating, for an area that's really, I think a lot of us don't really understand. Medical professionals don't understand. Rehabilitation counselors, we don't really get training in this area. And so I think it's a great service to us here today and to the profession. And just thank you so much.
Thank you, Chuck, for the opportunity. And I'd like to invite anyone within the sound of my voice to work to help people like myself and some of the participants in this presentation who've had ECT, so that they can get help for these episodic problems that come on. They're sudden onset, like swallowing or speech problems or falling, balance issues. And as rehabilitation counselors, we can encourage them and refer them for appropriate assessments. So thank you so much, and I look forward to sharing more information on the employment supports for people with a history of electrical injury in any form.